this Tuesday for a neurology morning report. And the usual introductory questions. Does anyone have a case they were hoping to present today, a neurology case? And ideally, we'd love to have two people to discuss that case with me, one identifying as a woman and one identifying as a man, if possible. Did anyone bring a case they were hoping to present today? Madalena's happy to discuss. Awesome. Happy to have you. Also doing teaching points. Okay, well, we'll figure that out. And did anyone bring a case that they were hoping to discuss? All right, activate plan backup case. Maria has a case from HumanDX, just in case. Someone else like to discuss with Madalena and myself? All right, Maria and Madalena, do you want to introduce yourselves and see if we can inspire someone to join you?
Yes, of course. I can go. My name is Maria. I have a case from the HumanDX. I'm a Guatemalan medical student. I love neurology. I love Neuro VMR. I promise it's really fun. And I think Abdulaziz already jumped in. So we have a case one.
You were so inspiring that we have Abdulaziz also. So Madalena and Abdulaziz, do you want to introduce yourselves and we'll get going before 9:07. This is a world record for volunteers, so thank you.
Yes, hello everyone. My name is Madalena. I'm a medical student who's finished her third year, but I'm taking a year off between my fourth year. So currently in California. And it's been a while since I discussed a neurology case, but I'm excited to just dive in and learn today.
Awesome. And Abdulaziz?
Hi everyone, my name is Abdulaziz. I am from Somalia, Somaliland. I'm graduate from Sudan and finished my internal medicine residency in Sudan. So I'm working now in Somaliland as internal medicine specialist.
Oh, congratulations. Since you last discussed, you finished your residency and you're back home in Somaliland. I think you discussed some cases with us from Sudan before. Congratulations. And welcome back. Fantastic. Well, happy to have you both discussing this case. And so, Maria, do you want to give us the chief concern and we'll go from there?
Yes, I'm very excited. The chief concern is diffuse pain and weakness.
Diffuse pain and weakness. Okay, Madalena, do you want to get us started with how you're starting to think about one or both of those concerns?
Yeah, so diffuse pain and weakness. So I think the first thing that comes to mind when I have two chief concerns is which one will allow me to kind of make more progress in the differential. And to me, I think I have a better approach to weakness than I do to diffuse pain. So I guess I'll start with the weakness. And from the many, neuro VMRs and podcasts I've listened to, we know that the differential diagnosis is localization times the time course. So I'm really wanting to hold kind of both of those as we work through the differential. And I think from some of the other neuro VMRs I listened to, a common branch point that is kind of something you want to consider initially when someone mentions weakness is their strength affected? So is there actual decreased muscle strength? And then you can, start to localize, is this in the central nervous system or the peripheral nervous system? But sometimes, someone could say that they feel weak, but really there's unaffected muscle strength. So maybe it's just a subjective sensation of tiredness. So that's kind of the first branch point I would focus on, is the strength actually affected? And then if it is affected, we can start to localize as in the central or peripheral nervous system. Those are my thoughts.
Excellent. And excellent thoughts they are, right? So this patient has pain and weakness, and I agree we could try to think about them together, but sometimes it's helpful to think of these things separately and then see where things overlap or how they might interrelate. And I agree, pain has such a broad differential diagnosis, right? It could be neurological, it could be related to the joints, right? It has could be visceral pain, could be referred pain, right? We'd be starting very broad if we try to put all of that together, right? But weakness, as you said, might give us a little bit more of a slightly narrower frame to start. But as you said, it could be anywhere still from the brain out to the muscles, and even proximal to that in our thinking, right? We have to understand if there's true diminished strength, right? Because we all know the feeling of feeling weak when we're sick and have the flu or have just gotten a vaccine and we feel weak. But if someone actually tested our strength, it would be 5 out of 5. We just feel weak. And of course, if a patient has pain, then they might also have the sensation of weakness in the sense that the pain is limiting their movement, right? I had a colleague who had a rotator cuff tear, and he said, he's a neurologist, he said, I can't move my arm. He said, I know that I can move it intellectually, but I really can't do it. And physically, he knew it would be a possibility, intellectually knew it would be a possibility, but something about the pain circuitry, right, is guarding or protecting that. And he said, I really can't move it. And I said, but you could, right? It would just be very painful. He said, no, I can't do it, right? So these pain and weakness can interact. So we may presume, since it's a neurology VMR, that the patient will have true weakness, although this is just a morning report, so we can't always presume that, and we don't always know with the patient. If we were thinking about weakness, then we could, as you said, start thinking about, is this central or peripheral, and then narrowing it down from there. Other thoughts on these chief concerns to pair with Madalena's thoughts, Abdulaziz, and then?
The symptom of diffuse pain and weakness, that's like a fake symptom. No one knows this is a real muscle weakness or it's just fatigability, like you say. But it's important to me to know this as an acute course or as a chronic course. It's very important to know that. So is an acute, I think about simple infection like influenza, COVID can cause diffuse pain and weakness, or it's a chronic thing. I will think a chronic condition, fibromyalgia, like that. So the duration and onset very important to know here.
Yeah, excellent. So once we have these chief concerns, right, our minds are already working on frameworks to start constructing a differential diagnosis. And with that broad framework in place, it helps us think about the types of questions we would want to ask. So of course, we'll want to know, has this been going on for a long time or not so long, or more sudden? Other questions, Abdulaziz and Madalena, you have on your mind that you're hoping will be answered in the history to start giving us some direction in this case?
I think, like Abdulaziz said, I think that the time course is key. So, how long this has been going on. Other questions I would want to know is, has this happened before? Have they experienced these periods of weakness? So that would clue us into, is this kind of a cyclic pattern? Let's see, any sensory changes would also be helpful to know. Do they have any tingling, for example, to see if there's kind of the peripheral neuropathy on top of the weakness. So some associated symptoms I would also be looking for.
Excellent. Yeah.
Maybe I am asking about cranial nerve involvement, difficult swelling, hearing. That's a question. Other question I will ask it in involvement, eye involvement like that. So to know this peripheral neuropathy, cranial neuropathy like that. It's very important question. Involvement of like joint, skin problem, to know this like myositis or dermatomyositis become like weakness, diffuse pain. So like this my hint.
Yeah, excellent. So we want to know the time course for sure. We want to know the age of the patient and any other medical problems they might have to contextualize what's going on. We would think about this very differently in an 88-year-old than we would in a 48-year-old and an 18-year-old and an 8-year-old, right? These concerns. And then the distribution, right, of these symptoms. We're hearing diffuse, but we'd want to tease that apart, right? And Abdulaziz said there'd be an important branch point. Is there anything going on above the neck, right, in the cranial nerve innervated muscles, or is this just the arms and legs? Is it proximal, distal, right? All of these patterns of weakness. You've seen these diagrams, right, where they have shaded sort of, if it's weak on face, arm, and leg on one side, that's just a contralateral hemisphere lesion. Face on one side, arm and leg on the other, a brainstem lesion. one sort of stripe on one limb, could be root, nerve, roots, nerves, plexus. If it's symmetrical below a certain level, suggests spine. And I say spine and not spinal cord, right? Because it could also be, if we're low enough, the cauda equina, so something in the spine if we had both legs. If it's predominantly distal, we would think more about neuropathies. If it's predominantly proximal, we think more about myopathies, though there are exceptions. We talked last time about non-length dependent neuropathies, demyelinating neuropathies, and there are a very rare set of myopathies that break this pattern, the distal dystrophies. There's Welander muscular dystrophy, Ud muscular dystrophy, Marksbury-Griggs, Nonaka, Myoshi, and Lang muscular dystrophies, which I memorized for my boards and then never saw, but I had a mnemonic for it. So they're always in there ready to pull out. These are distal dystrophies, myopathies that break the pattern of a proximal predominance. So, and then how do we put the pain with that, right? Presumably a cerebral lesion shouldn't be causing pain, but a spinal lesion, depending on if it's irritating the roots or the dura, could be causing pain. Neuropathies may be painful, right? Myopathies may be painful. I always presume that myositis, with that itis, that inflamed muscle, would be always painful, but often there's just weakness, and it's actually not always a painful condition, the inflammatory myositis. And then if we are localizing more to the muscles, given this diffuse sort of presentation, we can imagine we're about to hear that it is the arms and the legs, and it's maybe some proximal and some distal, and we're moving more towards the muscles. We can talk about approach to muscle disease. And I guess the other thing for weakness that wouldn't cause pain, we've talked in the course of our discussion about brain and brainstem and spinal cord and nerve roots and plexuses and nerves and muscles, but we don't want to forget the neuromuscular junctions, right? So Abdulaziz's point about, is there anything going on above the neck, is important, because for the weakness alone, right, we wouldn't expect myasthenia gravis to be painful, but a myasthenia gravis at presentation almost always is going to involve the eyes in some way, ptosis or a gaze palsy of some sort. Whereas those problems would be relatively uncommon with other causes of, some of the other causes of weakness we've discussed. Okay, so we're going to want to know the age of this patient. We're about to hear the time course. Is this episodic or chronic or acute or what have you? We're going to want to understand which parts of the body the patient feels symptoms in. As Madalena said, is this just weakness, or is there also sensory change? So is the pain accompanied also by numbness? The weakness accompanied by numbness, and any other systemic elements, as Abdulaziz said. Is there rash? Is there joint pain? Other things that might start cluing us into etiologies that there may be some systemic condition going on with neurologic complications. Okay, I think those are great questions to have from these 4 words going into our history. And now we have some sort of playing field, right, where we get to sort of figure out where we're going to focus once we have some more information. So, okay, Maria, tell us what's in the history now.
This was so, like, I'm not going to mention anything, but it was a great discussion. Abdulaziz and Madalena. So we have a 27-year-old woman with diffuse pain and weakness. She presented after several weeks of worsening muscle pain and weakness that have evolved, and now she's also presenting difficulties walking. She mentions that the pain and weakness are worse in the upper extremities, and they're worse sometimes in the morning. It takes around 20 minutes for her to stand up and start moving in the mornings. She also refers having difficulties with daily activities due to pain and stiffness in the upper extremities and neck. She's overall anxious about moving or being touched. And besides pain, she doesn't mention any other sensory abnormalities, and she doesn't mention any other symptom. That's like an outcome.
That's what we get. Okay. I think you started first last time, Madalena. So Abdulaziz, what are you making of this history here?
Okay, yes, I am reading now. So still I have not clear idea, but if you still like myasthenia gravis, the patient has become okay in the morning and have difficulty at the end of the day. So myasthenia gravis is not work like that. So I think that this patient like proximal myopathy is I think about that. Really, I don't have any idea now. Maybe.
Yeah. So what makes you think of this as a myopathy? I think that's certainly something I'm thinking about as well. So what aspects of the history led you to that area of the nervous system?
Like I said, you have worse in the upper extremity and have, I think, they are more than proximal, I think so, and difficulty in walking. So when you have upper extremity involvement, I feel like it's proximal, like a proximal myopathy for me.
Yeah, excellent. So it wasn't stated specifically, but the contrary wasn't stated either, right? It does sound that it's symmetrical, right? The patient isn't saying it's worse on the left, worse on the right. It's not specifically being stated that it's proximal, but I get that sort of feeling as well, in the sense that patients having trouble walking, that could of course be distal and could be a foot drop, but could be the proximal muscles we use to stand and support our gait as we're walking. The arms being involved, we haven't heard the hands and dropping things or things like that. We're hearing arm and not hand. So I agree, there's sort of some clues here that give a sort of, although not explicitly stated, a sense that this is proximal and symmetric.
Even the sensory is no sensory abnormality, so it's make peripheral neuropathy become the lowest differential, because if you have peripheral neuropathy, you have tingling sensation, burning sensation, your hand, your feet, abnormal sensation. So if you have no sensation, so I think peripheral neuropathy is becoming the lower differential now.
Yeah, excellent point. So we're hearing there's pain, which is a sensory symptom. So a little hard to say, but right, if this is pure weakness and we find on the exam as well, there's no sensory abnormalities, then that would put us somewhere in the motor system in places where sensation would be less likely to be affected. You mentioned neuropathy. You can get pure motor neuropathies where for whatever reason the disease process selectively affects the motor nerves. It's much less common than all the sensory neuropathies we see in diabetes and HIV and otherwise, although you can get sensory motor or sensory motor. But I agree, if you have pure motor and it's symmetrical and proximal, this seems to be building towards a muscle localization. I agree with you. Other thoughts, Madalena?
Yeah, so I think Abdulaziz, those are really fantastic thoughts, and a lot of what stood out to me you touched on and described really well. I think the age and the time course are really standing out, and I think for me, when I think through cases, I like to make a problem representation as early on as possible because it helps me just kind of summarize all of the data. So if the problem representation is the who, the what, and the when, I would say this is a 27-year-old female presenting with subacute, I'm putting the subacute bucket, subacute, like progressive muscle weakness and pain that's worse in the morning with no other sensory abnormalities. And both of you commented on kind of how this seems to be predominantly motor, and kind of the sensory abnormalities are not as emphasized. So I think my mind is going more towards the muscle here, but you did say that you can have predominantly motor neuropathies. And so those are the things that are standing out to me. And for the localization, we talked about, the central nervous system and the peripheral nervous system. And Robbie in the chat kind of walked through the peripheral nervous system. You can have the spinal nerve, peripheral nerve, neuromuscular junction, and the muscle. So I think I'm most focusing on the muscle, neuromuscular junction at this point, but I don't think you can exclude the other localizing parts, but that's where I'm focusing on right now.
Yeah, fantastic. And I agree. It's great to make a problem representation early, and we can always keep revising it and decide what stays in there and what doesn't. And what would you do, Madalena, with this problem representation? You've used it to help you with the localization. What about the time course part of the equation?
Yeah, so I think the fact that it's subacute, you can use to prioritize your differential. So, things like a stroke or some kind of vascular occlusion are more likely to be in the acute or even hyperacute bucket. So even though you don't want to rule those out, you just put them a little bit lower on your differential, and especially with the age, a 27-year-old, that's less likely in that population unless they have some risk factors for hypercoagulability. What else? So I think, I would just use the time course to prioritize different aspects of the differential.
Yeah, excellent. So yeah, the subacute, does that clue you in, Madalena or Abdulaziz, to particular set of etiologies. You mentioned that vascular etiologies tend to be sudden, hyperacute, so it seems less likely here, and to have a stroke that's affecting everything diffusely all at once, but the patient's awake and telling us about it seems somewhat less likely. Rarely you can get a stroke of the spinal cord, is pretty uncommon, but that also would be sudden, right? So this is not sudden, and so makes vascular less likely. What would you put in the subacute bucket for?
I think about ongoing inflammation, so inflammatory processes becoming top in my inflammatory process. Infection, about the infectious, it's become less likely, but inflammatory is the number one for me now. If it is autoimmune disease, like a part of SLE, a part of myositis, or mixed connective tissue disease like that. So I think I go with inflammatory now.
Yeah, I agree with you. This is a young, as far as we know, although maybe Maria is holding out some surprises for us in the past medical history of a bone marrow transplant and a history of something, genetic or something we don't know yet. But presuming this is an otherwise healthy young person with a subacute illness, certainly inflammatory conditions rise high in the differential. And if we're right that this is in the muscle, right, that is an important category of muscle disease. What else fits in a subacute category, whether in the muscle or not? Well, subacute infections, parasitic, fungal, neurologic complications of HIV can be more subacute chronic compared to bacterial, viral, which tend to be acute. Infectious myositis, you can get trichinosis, and there's, I think HTLV1 can do it, but these are pretty uncommon, but we don't know yet where the person is and if there's any. I think trichinosis, I've never seen it, causes facial swelling. Someone can fact check me on that. And then, yeah.
Even like we can, if we're focusing about the muscle, we cannot forget about metabolic disorder like thyroid diseases can be present, like weakness, anxious, and anxiety like that. So metabolic is becoming a differential.
Yeah, metabolic, I agree. And along with that, toxic conditions, right? So if this was an 87-year-old or 67-year-old with this story, and you could answer in one word what you think, and we'll talk about an approach to muscle disease in a moment, hoping we're on the right track. If not, we'll learn a little about muscles and have time to pivot if we're on the wrong track when we get to the exam. But if this was a 67-year-old with subacute muscle pain and weakness, and you could ask one question, I know this is like a guess what I'm thinking, but what would be a very common cause of muscle disease?
You could think of they're taking medication, so like a statin, for example.
Statin, perfect. Yep, you got it. That's right. So if someone told me I have this patient who's in, 50 or older and is having this muscle pain and proximal weakness, my first question would be, are they on a statin? What other medications they're on? That's right. So how to think about muscle disease? I mean, there are whole huge textbooks on muscle diseases. There are so many muscle diseases, but we can divide them into several broad categories, most of which we've mentioned. One is the inflammatory myositis, dermatomyositis, polymyositis, inclusion body myositis, and the more recently described immune-mediated necrotizing myositis. So inflammatory. And then we have toxic, which includes things like statins, prednisone, I think cyclosporin can do it, probably a bunch of antibiotics can do it as well. So inflammatory, toxic, and then genetic, which has its own branch points we'll leave out for a moment, and then associated with systemic disease. Now, others could split this up in different ways because many of those associated with systemic disease, although not all are inflammatory. So there's what's now referred to as overlap myositis, where a patient maybe has scleroderma and myositis, or maybe has lupus and myositis. But there are also, as has been mentioned, non-inflammatory. Well, actually, I don't know what the pathology is, but thyroid-associated myopathy, for example, I don't know if it's inflammatory or not, but the myopathy is associated with thyroid disease. So I divide into inflammatory, toxic, genetic, and associated with systemic disease. And then genetic, you can divide into the muscular dystrophies, of which there's a very long list, the mitochondrial myopathies, and the metabolic myopathies, which include all those glycogen storage disorders you memorize for step one and probably will never see in real life unless you're a pediatric geneticist. So that's sort of how I think about it. I'm sure Reza or Rabi would have a good mnemonic for whatever the 4 letters I had. What were they? Inflammatory, genetic, toxic, and associated with systemic disease. I guess I'm not thinking of a TIGS, STIG.
It could be gait.
Gait.
Genetic, yeah, genetic, A for associated, I for inflammatory, T for toxic, gait.
There you go, gait. All right, excellent. So we have a mnemonic to boot. Okay, excellent. So those are the things I'd be thinking about. And then this time, of course, inflammatory, we don't know what medications the patient's on. So that's the toxic is part of it, systemic diseases. And then could this patient have a genetic myopathy? We don't know the family history, though there can be germline mutations. I think the pain would be relatively atypical and the time course would be relatively atypical. And you might think, well, wouldn't the patient have presented much younger? Yes, with Duchenne or Becker's, but there's a long list of genetic myopathies. And where I used to work, there was a muscle specialist who saw all the very complicated muscle referrals and present us these cases of patients presenting in their 80s with a genetic myopathy, right? That it presented late. It was very mild and presented very late in life. So there's Duchenne's and Becker's, which present younger, but there's fascioscapulohumeral, there's limb girdle, muscular dystrophy, Emery-Dreifuss, muscular dystrophy, myotonic dystrophy, and depending on which mutation and some of them, I think some of them are repeat disorders. So how many repeats you get, don't quote me on that. I always get fuzzy when it gets down to the molecular level, but these are some things we could be thinking about, but if I had to prioritize, I'd say inflammatory. Then can we prioritize even further? We haven't heard about a rash, but sometimes the patients with dermatomyositis, the rash is not there at the beginning, and you can actually have the dermatomyositis rash without the muscle disease. So they can be dissociated. My muscle disease expert colleagues tell me that polymyositis is probably going away. It's probably a sort of grab bag diagnosis, and a lot of those patients probably have inclusion body myositis, or as we learn more antibodies, there's a tRNA synthetase syndrome, anti-tRNA synthetase syndrome. I think they have a lot of interstitial lung disease. So as there are more antibodies discovered, these things get divided into different conditions. And they told me that this polymyositis, which we think of for the boards, right, as dermatomyositis, sounds like dermatomyositis, but there's no skin findings, that a lot of those patients, that this may get carved away into other diseases over time. Still answer that on your boards or on your shelf probably, but very complicated area of neurology, muscle disease. And the genetics, we talk about limb girdle muscular dystrophy, it's like Charcot-Marie-Tooth. There's like 50 different genes that can cause it, and they have all sorts of different presentations. Anyway, we've talked about muscle disease. If it's something else, we better leave time just in case. And then I think the pain is something we haven't really discussed too much here, and we'll want to understand, is this pain in the muscles, actual muscle tenderness? Like I said, we would all think myositis should have that, but it doesn't always, but it can. Is this pain in the joints? This sort of worse in the morning does have a sort of joint flavor to it, inflammatory arthritis flavor to it. Is the patient so weak from a muscle process that they're kind of recruiting other muscles they don't usually use, and those muscles are sore? That could be some way of linking these two. Or are we way off here and the patient has a very painful sensory motor neuropathy, and the sensory part is very painful and they have motor as well? I agree with you both. That's not quite fitting for me, although I'm not sure I can 100% articulate why. Okay, so other thoughts before we get more information? Okay. Do you have any surprises for the southwest corner, Maria?
No surprises.
No
So
surprises.
has medical or surgical history. No significant social history as well. She has a family history significant for type 2 diabetes and thyroid problems. For the physical exam, all of her vitals were normal. She looked well appearing, but
give us 1 second. Yeah, sorry, 1 second just before you tell us. So, okay, so we don't have too much coming. Maybe if the thyroid disease is inflammatory, you might wonder whether that's another clue or not, but we'll leave that aside for now. What, Madalena and Abdulaziz, would you be looking for on the exam to either confirm our hypothesis of a myopathy, or what would surprise you and take you away from that diagnosis?
Yeah, I can jump in. So, going back to how we're trying to localize this from the central nervous system and the peripheral nervous system, and from the HPI, we're right now thinking or prioritizing the muscle. So with that, you would expect some lower motor neuron signs. Those are things like, reduced reflexes or even areflexia sometimes, hypotonia, or even some atrophy of the muscle. So I think those types of things would point towards being in the muscle, versus if we saw things that suggested an upper motor neuron, like increased reflexes or kind of spastic tone, that would be a little bit surprising to me, because that would more suggest that we're in the central nervous system. Abdulaziz, what do you think?
I think if the patient have proximal myopathy, the patient will have normal sensation in examination. The reflex most common is normal unless the patient have severe muscle weakness. The patient have difficult upper examination, difficult to raise his hand, and the lower have difficult to standing from the sitting position. That is going to proximal myopathy more than other thing. In examination, you can find painful tenderness in the muscle examination. Sometimes you can find it. If the patient have peripheral neuropathy like that, it has signs of lower motor neuron lesion more than that, like hypotonia, hyperreflexia, sensory involvement. So this is my idea.
Yeah, excellent thoughts, both of you, right? So if this is muscle disease, most of the time the weakness should be proximal. So we're looking at weakness in the shoulder girdle and in the hip girdle, right? So you can ask the patient to cross their arms and try to stand up from the chair. That requires a lot of sort of core iliopsoas muscles, and the patient might have difficulty doing that if they have proximal weakness. Patients with proximal weakness might say they have trouble getting things off of a high shelf or washing their hair, or things that require their arms to be above their head. And we could be testing that starting from proximal to distal. As I mentioned, there are exceptions. There are distal myopathies, but they're incredibly rare. It was great also to think about, as you said, Madalena, where would our surprises be if we saw upper motor neuron signs here? Well, back to the drawing board, right? We weren't thinking brain or spine in this patient. Spine diseases can cause symmetric symptoms. All this pain in the muscles themselves would be a little bit hard to interpret in that context. And we certainly weren't expecting bilateral brain disease, right? This patient's awake and talking, and as far as we know, although Marie's going to tell us there's nothing going on above the neck. And as you said, if this was in the peripheral nervous system, we could see hyporeflexia, atrophy, those sorts of things. One slight nuance to point out, although we sort of say upper and lower and we gloss central and peripheral, the muscles are sort of in some ways outside of that system, right? So technically, if you have a myopathy, your reflexes should still be preserved. Your reflexes should still be preserved. And the reason is that that is something that's transmitted from the nerve, from the sensory organs, right? Through the nerve, through the root, back through the motor nerve, right? So unless the muscle is so weak that the patient doesn't have enough strength to generate the reflex, then you could have decreased or absent reflexes in muscle disease. But presuming that this patient, we don't know how weak they are, but is strong enough that they made it to this appointment. We don't know if they're being carried or in a wheelchair yet, but if not, and we can see that they have sufficient muscle bulk, they should be able to still generate a reflex, and that would be one thing that would help us here. Atrophy, of course, yeah, severe muscle disease can cause wasting of the muscles. You've probably seen some of these striking board review pictures. I think it's facioscapulohumeral dystrophy, where they have like a triple bump, or they call it the Popeye arm, where there's sort of selective atrophy of muscles that make the shape of the arm or shoulder look particularly characteristic of that disease. So atrophy, yes, because the muscle itself is being affected, but reflexes should be spared, as they should be in myasthenia gravis. Just to put it out there, gourmet neurology, but in Lambert-Eaton syndrome, which I've never seen a case of, if someone's seen a case, please tell me. But if you see Lambert-Eaton, it's a presynaptic neuromuscular disorder. We won't get into the physiology of why this occurs, but you can actually lose the reflexes in that neuromuscular disease. And by having the patient exercise the limb for a little bit, you can actually bring them back. So that's a very striking finding, but I would be sad to diagnose a patient with that condition, but would be glad to elicit and be able to think of that condition from that unique exam finding. But in general, what you said is true for the upper and lower motor neurons, but the muscle is sort of distal, right, to that. So if this is a muscle disease, we should see intact reflexes unless the muscles are so severely atrophied that they can't pull on across the joint. So I agree, if we're on the right track, we should see proximal weakness, normal sensation, and normal reflexes. And the question will also be what and where is this pain? I think someone mentioned earlier fibromyalgia is this pain at particular points that can be mapped. And if I'm considering this diagnosis, I always pull up the image on Google Images for the patient, right? See how when I pushed in these places, it fits right with this disorder where we don't know the cause of that, but it's been described that these areas are painful. Or is this pain in the muscle bellies themselves? Is this pain in the joints, which we'd have to reckon with and add to our differential diagnosis. Okay, sorry to have paused you, Maria, but always good to know before we go into the exam what we are thinking we might see if we're on the right track, and but being open to being surprised and having to revise our problem representation. Okay, what do you have for us, Maria?
Okay, so let's see if I can answer some questions. The vitals were normal. She was well appearing, but she was diaphoretic. All of the systemic physical exam was normal except for tachycardia, but the rest of the cardiac exam was also normal. She had tenderness to palpation and sensitivity to light touch of the neck and shoulders. The patient was only able to raise arms up to 90 degrees. So beyond 90 degrees, she wasn't able to raise the arms. The exam had to be interrupted because the patient cried out in pain intermittently with visible muscle spasms. The pain was unresponsive to opiates, but it was relieved by benzodiazepines. And other than that, her cranial nerves were intact. The strength was 5 out of 5 in bilateral upper and lower extremities, with exception of the shoulder abduction, which was 4 out of 5, and the reflexes were normal. And that was the aliquot.
Okay, where are we now?
Abdulaziz, do you want to go first, or if not, I'm happy to jump in, whichever you prefer.
I'll go first.
Okay, so from our discussion that we just had, which was very helpful kind of leading up to this, it seems that we are most likely in the muscles. So Aaron taught us that in myopathy or muscle pathology, the reflexes can be spared, which we do see here that the reflexes are normal. And we also see the proximal muscle weakness, the 4 out of 5 shoulder abduction. I think what's also standing out to me is the pain here. How, Maria, you said that the physical exam had to be interrupted because of how intense the pain was. I think, what is the term? It's like a I don't know if this is right, hyperallodynia or something like that. So I don't think I was expecting the pain to be as so prominent compared to the muscle weakness. So that's something that's standing out to me, but I'm not really sure what to do with it. But what I'm taking away from this exam is that we are most likely, if we think of a localization, we're most likely in the muscle, given the proximal muscle weakness and the spared reflexes. Abdulaziz, what do you think?
Yes, I am going with the muscle disease, but the neck pain, severe neck pain, that is very weird for me. And the muscle spasm, really, that's not common like that. But the patient have like tachycardia, diaphoresis, difficult to abduction, even thyroid disease I cannot exclude in this patient. But I put my mind if there is any cervical diseases that making severe neck pain and difficult to uprise in the shoulder, I put the cervical illness of cervical lesion in this my mind with thyroid disease.
Yeah, excellent thoughts, both of you, right? We have nothing in particular to suggest the nerves, right? The reflexes are spared, the sensation is spared. The weakness is not really maybe as diffuse as we were anticipating. It is proximal, but it's just in the upper extremities. And then, as you both said, although not clear what to do with it, what to make of it, the pain is a very significant part of this. We said from the beginning, we're going to have to reckon with both of these, and it's a little more narrow in scope to start with the weakness, but the pain seems to be the prominent symptom for the patient. And what do we do with that? And it seems like, at least from the information that Maria has from the case, or has as from the casing I shared with us so far, that the pain is being caused by muscle spasm. Was the gait described? Oh, you just put it in there. Did you mention that? Yeah, I
forgot to mention it, but they describe it as rigid.
Yeah. So there's muscle spasm and a very stiff gait here. There's a diagnosis that's bubbling up for me. Not to play guess what I'm thinking, but a sort of a gait that seems stiff and rigid, muscle spasms, pain. Any thoughts on?
It's like muscle stiffness and stiff person syndrome. It's very rare to think about it. Yeah, maybe.
Yeah, that's what's on my mind a little bit too. Stiff person syndrome, which I've seen maybe 2 cases. I just saw one very striking case this last year. That certainly came to mind for me when we hear about this rigid gait. The arms being so affected is a little bit confusing to me. Usually the stiffness is more concentrated in the lumbosacral region, and that's part of why the gait is abnormal. Tell us what you know about stiff person syndrome, because that's where my mind is going as well, Abdulaziz, and then I'll fill in.
Really, I don't know a lot of information. Just I know that patient have muscles become very rigid, stiffness like that. That's it. My knowledge about stiff person syndrome.
Yeah, is this something you're familiar with, Madalena, or?
Not very familiar. I believe, I think it's an antibody-mediated process. But besides that, I don't know much about that syndrome now.
Yeah, excellent. Well, it's not a common syndrome, but these are often patients who are misdiagnosed or go to many providers for a while because they have a lot of pain, they have a lot of stiffness, and they might not have too much to show for it on the exam. And so this is an antibody-mediated disorder. Either of you know the most common antibodies? It's okay if you don't, it's a very rare condition. No. So GAD65, but be careful, GAD65 is when you send an antibody panel to Mayo Clinic or Athena, wherever you send it to, it's not uncommon to get a mildly elevated GAD65, and it's not clear what it means. I think it's very common to see in type 1 diabetes. Doesn't mean the patient has a neurologic condition, but I've seen a lot of consults for the patient had a neurologic thing. We didn't know what it was. We sent antibodies. We got a mildly elevated GAD. I don't know the exact threshold, but it should be sufficiently high to invoke it. And we've talked about antibody-mediated syndromes before in this morning report. Some antibodies sort of only do one thing, like the Nmda receptor encephalitis is a very characteristic syndrome, which you can read about. We won't get into it now since that has nothing to do with this case, but that is very characteristic, and that antibody causes that syndrome. On the other hand, there are many antibodies that can cause limbic encephalitis, of which Nmda is one. And there are some antibodies that can cause multiple neurologic syndromes, either in a paraneoplastic context or in simply autoimmune non-paraneoplastic context. And GAD65 is one of those. It can cause stiff person syndrome. I believe it can cause cerebellar ataxia, though someone should fact check me. I believe it can cause Parkinsonism. So it can do lots of different things. So some antibodies, one syndrome, some syndromes, multiple antibodies can cause it, and some antibodies can cause multiple syndromes. So GAD65 is common, anti-glycine, I believe, and anti-amphiphysin. And I think that the amphiphysin is more associated with finding an associated cancer. And the other clue here is that Maria told us, though I'm not sure it ended up getting written down, was that the symptoms resolved with benzodiazepines, and the symptomatic treatment of this condition is diazepam. And these patients can tolerate extraordinarily high doses of diazepam that would put most people to sleep from the sedating effects. So of course you want to start at a low dose and see how the patient tolerates it, but sometimes you'll see these patients and they're taking 30 milligrams of diazepam 3 times a day, and you think, how are you awake? But clearly, I don't know how this works pharmacologically, but the muscles know they need it, or not the muscles, the nervous system knows it needs it, and it's taking it, and not somehow the sedating properties are not there. So if you can get the symptoms under control and you haven't found a cancer, diazepam can sort of be the treatment. But if that's not working, or that doses needed are high enough that the patient is having side effects, then I believe IVIG is used. So that's where my mind went. So I'd want to, there's no imaging test that would show us anything here. For a rigid gait and for all this spasm for a primary muscle disease would be a little atypical. There can be myotonia, obviously, and myotonic dystrophy and some cramping, but these sort of very prominent spasms to the point they're affecting gait, that I can't think of a myopathy where you would see.
So,
yeah.
So what about differential about tetanus?
Yeah, so tetanus is a great thought, right? So something do you see a lot of tetanus in Sudan and Somaliland? Yeah.
I see it like 2 patients per year, like 3 patients. Yeah, I see it.
Yeah, so maybe you can teach us. It's something we read about, but we don't see too much here. I guess I would say as a first pass to have this sort of subacute course would be atypical, from what I know. But why don't you tell us how, when you've seen patients with tetanus, how are they usually presenting?
Most of the patients present like generalized spasm and intermittent by twitching. Even the abdomen become rigid. This patient is become like neck stiffness. Some patients have like tetanus. Clearly, you can see it. You can see like this book of tetanus here in Africa.
Yeah, I've seen, I think, one case when I've worked in Malawi, and one probable case in an infant in Haiti. Yeah, the spasms are very dramatic, right? The patient is arcing their back, epistatonus, the jaw is clenched. There's apparently a very sensitive and specific sign called the spatula sign. If you put a tongue depressor in the mouth, the patient bites down on it and can't let go. And then this progresses to very severe autonomic instability as well. And patients need to be intubated and given extremely high doses, again, of benzodiazepines, and unfortunately often in the areas of highest incidence, some of those resources are not available. But the 1 or 2 cases I've seen are very striking for how these spasms are just involving the whole body, as Abdulaziz said. So for this sort of subacute course, to make it this long and just have some sort of mild or moderate rigidity and just of the gait and be a little atypical. But yes, in our differential diagnosis of a disease causing stiffness without clear localizing properties on the exam, that's a great thought. I may be getting framed with stiffness responding to benzodiazepines and a rigid gait and all of this pain and spasm, and having trouble now thinking of other things this could be. So what would we do next to try to get an answer here?
So you mentioned the antibodies, and those probably take a while to come back, but I would definitely send that. Again, I don't know much about the syndrome, so I'm curious, would an EMG be helpful in this case? Yeah, I don't know.
Yeah, good question. You can do an EMG. I think the patient I saw recently, the symptoms were so classic, and I asked the neuromuscular person, would they do an EMG? And they said, it's just going to show you what you're seeing on the exam, that the patient has severe muscle spasm, and you can feel it and you can watch it happen. I'm not going to do an EMG. I said, okay. But you could if it was ambiguous or you weren't sure, and then you would see diffuse muscle hyperactivity, I presume, if I'm not mistaken. You can send the antibodies. You would screen for underlying cancer. Do you need CSF to make this diagnosis? I don't think so, but I'm not sure. I think you would see inflammation in the CSF, but I'm actually not 100% sure. I think that you would, but with a classic syndrome and the antibody, someone can check me. I think you can make the diagnosis that way.
I thought it.
What is it? Okay. So what did the Human DX people do next, Maria?
Okay, so we got some labs. CK was mildly elevated at 405. CRP was also mildly elevated at 17.42. ESR was mildly elevated at 47. They did a chest CT, which showed a left anterior superior mediastinal mass with associated pleural mass and enlarged cervical lymph nodes. And they did send some antibodies that are pending, let's say.
Okay.
Wow, I was not expecting that. Abdulaziz, do you want to go for it?
Yeah,
Or, yeah, go for it, please.
it's like maybe they become we have CT chest with masses, so it become like symptom of paraneoplastic syndrome and autoantibody that will make you muscle stiffness. Maybe like a Lambert Eaton syndrome is becoming a differential. Paraneoplastic muscle disease. So it is very interesting case really.
Yeah, I agree. Oh, go ahead, Madalena.
Oh, and I was kind of just going to echo what Abdulaziz said. I think when I see this left anterior superior mediastinal mass and a pleural mass, I'm in conjunction with this, muscle weakness and pain. I think of the Lambert Eaton syndrome. However, that said, my understanding of that syndrome is you generally have reduced reflexes and you have some autonomic symptoms like dry mouth, constipation, things like that. I'm not sure if maybe you can have that syndrome and have those features absent. I'm not entirely sure, but that's what's kind of jumping out to me.
Yeah, so we all hear mediastinal mass, pleural mass, right? We're presuming some relationship to the primary syndrome. Yeah, the pain would be atypical to my knowledge to Lambert-Eaton. Like I said, my knowledge of Lambert-Eaton is only from reading. So if someone's seen a case, please correct me. But I'm sorry, go ahead.
Yeah, isn't it the painful is atypical for Lambert Eaton if the patient have areflexia, dry mouth, even I think there's something with raises in the eye. So not that going with Lambert Eaton, yeah, not that typical for him.
That's right. Usually they present with proximal weakness, so you could get fooled for a myopathy, but they often have autonomic symptoms, pupillary abnormalities, orthostasis, and then, as we mentioned before, they have diminished or absent reflexes that are actually facilitated by exercise, the opposite of myasthenia. So I don't think we have a clinical fit there. Yeah, go ahead.
Even if the differential diagnosis of superior mediastinal mass, maybe like thymoma, lymphoma, these becoming different top differential thyroid malignancy. This is the top differential of superior anterior mass.
Yeah, you. I defer to you, internist, to say what you think the mass is. For me, the concern would be that this is in some way associated with the stiff person syndrome, and that it is indeed paraneoplastic in this case. I'm not sure if there's a particular malignancy association. For example, we mentioned Nmda receptor encephalitis earlier. The most common neoplasm associated with that is ovarian teratoma, although only about 50% of patients have that, and some have other tumors or no tumor at all. So there are some, again, getting to this complicated world of paraneoplastic and antibody-mediated neurology, cancers with a particularly associated antibody associated with a particular syndrome, but some syndromes can be caused by multiple antibodies, some antibodies can be caused by multiple different cancers, et cetera. So there's lots of different things here. So I presume we need a biopsy of that thing to figure out what it is and how to treat it. I guess in this age group, I'm really getting out of my expertise here, but could she have, you mentioned lymphoma, could this be Hodgkin's lymphoma? And I'm not sure how commonly Hodgkin's lymphoma is associated with paraneoplastic conditions, or lymphoma in general, although anything can do anything. So we're going to presume association, but we'd want to see those antibodies and we want to know what this mass is. And would we ever be able to definitively prove that this mass is causing the production of these antibodies? It's hard to say. Or is this some type of thymic mass that is just dysregulated the immune system, and as such, there's some friendly fire developing and these antibodies are developing. So we probably want to send the GAD, the GAD65, anti-glycine and anti-amphiphysin, and biopsy this mass. And we have 4 minutes left for Maria to tell us what's going on here.
Okay. Okay, I'll say it. So the final aspiration of the mediastinal mass was consistent with a thymoma, and 2 antibodies came back positive: acetylcholine receptor antibody positive and glutamic acid bicarboxylase 65 antibody above 200, so positive. And that's the end.
Did they tell you how they treated the patient, or?
Yeah. So the diagnoses were, do I say it?
Oh, well,
yeah.
So let's first say, does this patient have myasthenia gravis?
So, So myasthenia gravis, my understanding of the pathophysiology is you have, antibody to the acetylcholine receptor, which, Miri, did you say that those are positive? Acetylcholine receptor antibodies, positive?
Yeah, they are. GAD65 and the acetylcholine receptor antibody.
Interesting. So, I mean, my understanding of myasthenia gravis is that the pathophysiology is that antibody, so that I'm not sure if you can have a false positive, but the GAD65 antibody, yeah, I guess I think I would be curious about the sensitivity and specificity of those. I don't know much about the stiff person syndrome, but if that antibody is positive, perhaps that's what this person has. But I am curious about that positive acetylcholine receptor antibody.
Okay, yeah. I remember that thymoma have specific factor of Myasthenia gravis. So the thymoma cell can cause paraneoplastic like acetylcholine antibody positive. Even if you have patient with Myasthenia gravis, you must do CT chest or chest X-ray to exclude thymoma for Myasthenia gravis. So I think that malignancy can ability to do a lot of paraneoplastic. This is my suggested.
Yeah, so this is the challenge in sending these antibody panels, right, where we get a bunch of stuff back. Clinically, the patient does not have myasthenia, right? They don't have fatigable weakness. There's nothing going on in the eyes, and they have all this pain, right? So the syndrome doesn't fit. The syndrome does fit with stiff person, and we have a positive antibody. And if we have a thymic lesion, I think all bets are off, and the patient may have lots of autoantibodies, right, that are being produced. So you'd have to treat the right symptom. Now, could this patient also end up developing myasthenia in addition to this? Is the weakness in the upper extremities myasthenia and the stiffness in the back GAD65, and the patient has two diseases? But again, there's not really a lot going on for myasthenia here. I guess you could do an EMG with repetitive stimulation and try to see if you could see through the spasm if there's a decrement and you have evidence of neuromuscular junction disease there. But I wouldn't know too much what to do with that in this context. And if it's a low titer, I think it's pretty specific. I mean, but if it's a low titer and the patient doesn't have the syndrome, at least at this time, I would probably err on the side of treating the prominent syndrome and thinking that that's just showing that the patient has a lot of antibodies being produced. In the opposite situation, right, if this patient had clear myasthenia and GAD65 came back mildly elevated, you'd say, no, the patient is having an autoimmune predisposition and happens to be making this antibody as well. But it's not causative. So watch out for that GAD65 because you will see sort of a mildly elevated antibody without a correlated syndrome. So I would still call this stiff person. Does the patient have both? From what we know, not yet. Although that shoulder abduction weakness, I guess I couldn't really explain from stiff person. So what did the people who wrote this case think, Maria? Does the patient have one disease, two diseases?
So that's like the interesting part about neurology. You get all of these like antibody panels and like MRIs of everything, and you still need somebody to be behind them and analyze them. So the final diagnosis was stiff person syndrome. I'm sure about the myasthenia gravis syndrome. So stiff person syndrome, as you've mentioned, it can be paraneoplastic, and it has been reported with thymomas, and it's also an autoimmune disease. So it's associated with other autoimmune conditions, one of them being myasthenia gravis syndrome. So there's case reports of stiff person syndrome with a thymoma, and there's also case reports of stiff person syndrome and myasthenia gravis. So in this case, they decided to treat for both. So initially, patient was treated with benzodiazepines and plasma exchange for both stiff person syndrome and myasthenia gravis, and she underwent a thymectomy with mass resection. She was eventually discharged with outpatient follow-up and only a benzodiazepine. So that was the final diagnosis.
Excellent. Well, yeah, go ahead, Abdulaziz.
Yeah, it's very interesting, beautiful case. Yeah, very nice case, really. Yeah, I'm learning a lot of this case, really. Thank you for this case.
Yeah, great selection from Human DX, Maria. Yeah, that's interesting case, right? We started with what we saw was diffuse, and we localized to the muscles, and we went through our whole schema for myopathies, which ended up, we knew going along that the pain was a probably overly prominent symptom. And once we saw the muscle spasm, we knew that we need to think maybe a little bit outside the box here. So stiff person syndrome is out there. You might see it. Like I said, I think I've seen one as a resident who was being followed by an attending I worked with. And just recently we saw a case that just over the phone sounded so much like it. And when we saw the patient, even just sitting up in bed, you could see her legs go into severe spasm. Her calves were kind of rock hard. The patients usually have sort of a hunched gait, and there's just sort of almost like a big bump of muscle spasm in the lower spinal, paraspinal muscles. And they get better with benzodiazepines, or in some cases immunomodulation. And then of course we want to screen for an underlying tumor, although you would have thought a healthy 27-year-old woman, the likelihood of finding a tumor would seem low, but when you see these antibodies, they can be paraneoplastic or independent of neoplasm. So you need to look. What to do with the myasthenia antibodies, I'm not sure, but yeah, if you're plasma exchanging, I guess you're cleaning out all the antibodies and you're taking out the thymoma, and then see how this patient does, treating the prominent symptoms with the benzodiazepines. I don't see how pyridostigmine would necessarily help this patient's symptoms, though we'd want to see, once we got that antibody, we'd bring the patient back and see, is that shoulder abduction weakness fatigable? So you can have the patient put both arms up and you push and get a sense of the strength on both sides, have them rest one, and then 50 chicken wings on one side, and try to fatigue the muscles and then test them again. And you have an internal control, and if you can sort of test fatigability that way. But myasthenia with nothing in the eyes, it can do, but there's almost always eye stuff at presentation, but almost is only almost. All right, well, quite a case, excellent discussion, Abdulaziz and Madalena, and good reminder for all of us to go review stiff person syndrome so we can pick it out of a crowd if it walks into our clinic, emergency room, or ward. And whoever has teaching points, feel free to tell us.
Hi, yeah, so teaching points will be when we start with the weakness differential. We have to know if it's acute, subacute, if it's where is it localized, if it's pain, if it's proximal or distal, symmetric or asymmetric. It can be the predominant feature of this primary muscle disorder, such as dermatomyositis, polymyositis, etc. Subacute courses, paratarsus vasculars, or inflammatory TL. Since viral and bacterial are normally more acute, and reflexes are also preserved myopathies is a very important point to take care into consideration. And we had a great mnemonic for weakness. It's gait, genetic, associated with systemic disease, inflammatory, and toxic, where it will be all these medications that will cause muscle weakness, and like special pearls for the diseases that we saw today was a stiff person syndrome that affects women predominantly. It is related to the glutamic acid decarboxylase 65 anti-amphiphysin antibodies. It affects spinal cord and brain. The patient usually presents with painful spasms, rigidity, impaired mobility, heightened sensitivity to noise, sudden movements, and emotional distress. It is shown that with electromyography, you can find somehow the diagnosis. I am still reading about it. And it is also associated to paraneoplastic variant, which will have more significant stiffness in the neck and upper extremities. We also had two other diseases, the Lambert, Eaton, and Myasthenia gravis. Both one improves with exercise and movement and starts with proximal limb movements, while Myasthenia gravis is associated with thymomas, and it starts with weakness in the extraocular muscles and worsens with exercises. And both will be confirmed by the type of antibodies you could find. So I really like this case. And yeah, I think we will all be reading about stiff person syndrome today.
Excellent. Where would you read about stiff person syndrome? If you want probably the most detailed discussion, if you have online access to the movement disorders textbook, I think it's Jankovic and Fawn, Principles and Practice of Movement Disorders, or something like that. It's, I think it's an Elsevier book, Clinical Key. Some people know I'm moving, so all my books are packed up. I can't show it to you. the AAN's continuum, which you might have trouble getting access to, although you could become a student member of the AAN if you like neurology and get access. It's a wonderful, very clinically practical journal where they cycle through all the major topics over every 2 years, every 2 months. So you can find the recent movement disorders issue, although I'm not sure there's an article on stiff person syndrome in there. And then I'm not sure if it's available online. I'm trying to see the book on my shelf. It's a blue book. I think it's a Springer book. It's therapy of movement. I think it's called Treatment of Movement Disorders or Therapy of Movement Disorders. Stephen Frucht is one of the authors. It's very short articles, essentially on every movement disorder, and with a little case presentation of very, very excellent movement disorders books. Or of course, how did I not say Up to Date? I'm sure Up to Date has an excellent article on this as well for a quick pass. But if you want the sort of neurologist, by the neurologist, for the neurologist, that Fahn and Jankovic is an incredible movement disorders textbook. And then the more recent, it's called Treatment of Movement Disorders, Therapy of Movement Disorders. It's a blue book, and is it Stephen Frucht or Stephen Reich? They're two movement disorder specialists that always give a lot of lectures.
I think I found the link. So I don't know if it's the one in the chat.
Oh, let's see.
Therapy of Movement by
Is it
Stephen
Frucht or
Reich.
Reich? Stephen Reich. And yeah, there's a Stephen Reich and a Stephen Frucht, who are both movement disorders persons. I think have both written books. That's the one, a case-based, very, very good movement disorders book if you can get it through your library. Excellent. Well, thank you, Maria, for selecting this case. Thank you, Madalena and Abdulaziz, for joining us and discussing. Hope we all learned a little bit about stiff person syndrome, and we'll see you next week.
Bye, everyone.
Bye. Thank you.